Good day, everyone. I'll be sharing the updated evidence-based strategies for pharmacologic management of CRHM or Cardio Renal Hepatic Metabolic Syndrome in the primary care setting. In this presentation, we will integrate the latest clinical data focusing on how frontline physicians can optimize therapy using current guidelines, rational drug selection, and patient-centered approaches. The goal is to translate evidence into everyday practice, ensuring that management of CRHM syndrome is not only effective but also accessible, safe, and aligned with national standard of care. So here's my opening remarks. Since CRHM represent overlapping conditions and comorbidities, an integrated care approach is essential. Given that this presentation focuses on pharmacologic management, then I will concentrate on the clinical benefits of available medication that helps mitigate CRHM. Accordingly, the role of primary care clinician is to recognize CRHM early, ideally in its initial stages, so that this therapeutic agent can be introduced at the most appropriate time for maximum organ protection. However, if recognition occurs later, then prompt referral to the appropriate specialist without delay is critical to ensure timely intervention. So in short, detect early, protect the organs, and refer promptly when necessary. So I'll begin by briefly examining the epidemiology burden and intricate interplay of cardiorenal hepatic complication in diabetes and obesity. From there, we'll move into updated pharmacologic evidence highlighting therapies that demonstrate true organ protection. From the mechanistic insights to pivotal trial data, and finally, I'll outline practical guidance for primary care integrated recommendation for major specialty group including the ADA, EASD, the AACE, the AHA, and the DCRM 2.0 frameworks. Well, a systematic analysis for global burden of disease study in 2017, the cardiorenal metabolic disease is a global health challenge with millions affected by heart failure, diabetes, and chronic kidney disease. Now, put this together, this interconnected condition drives enormous morbidity and mortality, underscoring urgent need for integrated prevention and management strategies worldwide. Now, large multinational studies reveal that in patients with type 2 DM, chronic kidney disease and heart failure most often emerge as the earliest cardiorenal complication. This is taken from a large multinational cohort study, mostly European countries and also Japan. Patients were followed up for an average of 4.5 years. As you can see, the bar graph, CKD or chronic kidney disease and heart failure are the two most frequent OPD complications in type 2 DM. So heart failure and chronic kidney disease and diabetes are deeply interconnected with millions affected worldwide. The overlap is striking. Nearly half of patients with heart failure also have CKD and up to 40% have diabetes. Likewise, 40% of people with diabetes develop CKD. Shared drivers, obesity, inflammation, vascular disease, AIDS, hypertension, smoking fuel this triad. This underscores how this condition cluster magnifying risk and burden and highlights the urgent need for integrated cardiorenal metabolic protection strategies. Well, this map reveals the pressing reality that more than half of people with overweight and or obesity worldwide have muscle D, with prevalence ranging from 31% in Northern Europe to over 80% in Eastern Europe. Rates are consistently high across the Americas and Asia, underscoring the muscle D is a global epidemic. The key message here that liver disease is a systemic consequence of metabolic dysfunction, demanding early detection, proactive management, and strong public health action. Well, this data remind us that type 2 DM does not exist in isolation. It overlaps with obesity, CBD, CKD, liver disease, and heart failure. The numbers are striking. Up to 90% of patients with type 2 DM are obese. 1 in 4 patients with type 2 diabetes already live with CKD or heart failure, a heavy burden in itself. And here what makes this more interesting is that the liver is affected even more than half, and up to 2/3 develop fatty liver disease. Well, this imbalance reminds us that while kidney and heart complications are common, fatty liver is even more pervasive. Together, these comorbidities show that diabetes is not just about blood glucose. It is a systemic condition demanding integrated protection not only of the heart, kidneys, but also the liver. Now, tracing the evolution of cardiorenal hepatic metabolic syndrome from its 1998 origins to the expanded 2025 framework, and now integrates cardiovascular, renal, and hepatic domain. Now, type 2 diabetes driven by insulin resistance is a central hub linking dysfunction in the heart, kidneys, liver, brain, and blood vessels. Shared pathways, chronic inflammation, oxidative stress, lipotoxicity, and microvascular injury fuel coronary artery disease, heart failure, atrial fibrillation, stroke, cognitive decline, diabetic kidney disease, steatotic liver disease, and peripheral artery disease. These organs' interaction highlight diabetes as a systemic disorder demanding integrated multidisciplinary risk management. So in short, diabetes is not confined to sugar. It is a systemic condition orchestrating heart, kidney, liver, brain, and vessel dysfunction. Managing risk means treating the whole continuum, not just blood sugar. It's not just diabetes. Obesity and dysfunctional adipose tissue, sometimes called diabesity, triggers the cascade of metabolic and inflammatory disturbances. Through adipokines and cytokines, ectopic fat deposition develop, including muscle D, fueling inflammation, oxidative stress, insulin resistance, and vascular injury. This mechanism drive hypertension, dyslipidemia, and diabetes, the classic cluster of metabolic syndrome. Simultaneously, they damage the heart via atherosclerotic remodeling and fibrosis, and the kidney via glomerulosclerosis and tubulointerstitial fibrosis. Heart and kidney injury then reinforce each other bidirectionally, worsening disease through cardiorenal syndrome, albuminuria, and neurohormonal activation. So why unify care is important? Now, the answer is because diabetes, obesity, and related cardiometabolic disorders share common pathways such as insulin resistance, inflammation, oxidative stress, and endothelial injury that fuel multi-organ dysfunction. Treating this condition in isolation misses the opportunity to use therapies with proven cross-organ benefits. Now, the current guidelines from ADA, AHA, EASD, and the DCRM 2.0 emphasize integrated care models and early use of agents like SGLT2 inhibitor, GLP-1RAs, to deliver protection across the heart, kidney, liver, and the metabolic system. So, what are the practical core clinical targets? For the heart, focus on ASCVD prevention and optimize heart failure care, including congestion management. For renal, monitor eGFR trend and aim to lower albuminuria. For the liver, track steatosis activity and evaluate fibrosis risk using non-invasive assessment. Metabolic, address weight, glycemia, BP or blood pressure, and atherogenic dyslipidemia. Now, after reviewing all the pathophysiology, integrated care, and monitoring, we now focus on the therapies for CRHM. SGLT2 inhibitor and GLP-1 RAAS, once designed for glucose control, now show broad organ benefits. SGLT2 inhibitor improve renal hemodynamics and filtration, while GLP-1 RAAS reduce atherogenesis, improve lipids, slow gastric emptying, promote satiety, and may offer neuroprotection. Used together, they provide synergistic effect, lowering glucose, reducing CV event, improving insulin sensitivity, supporting weight loss, lowering blood pressure, and protecting kidneys, delivering comprehensive metabolic and cardiorenal protection in type 2 DM. Now, clinically large cardiovascular outcome trials, the CVOTs, have shown that GLP-1 RA reduce major advanced cardiovascular event, MACE, like stroke and mortality, while SGLT2 inhibitor lower heart failure, hospitalization, and protect kidney function. Beyond these proven outcomes, both shared anti-inflammatory and antioxidative actions with complementary metabolic effect. Put it together, they provide robust, evidence-based cardiorenal protection in type 2 DM. Now, across 6 cardiovascular and kidney outcome trials of SGLT2 inhibitors in type 2 diabetes, including patients with or without ASCVD, this agent consistently lowered the risk of major adverse cardiovascular events, hospitalization for heart failure, and kidney outcomes. The reduction in heart failure risk was uniform across studies, while kidney disease progression showed moderate variability between trials. Now, I want to remind everybody that among GLP-1 receptor agonists, only some agents, not all, demonstrated cardiovascular benefit in their individual CVOTs. The ones highlighted in red are those with proven CV benefit and are available in the market. However, overall, the CVOT evidence shows in meta-analysis that selected GLP-1 RAs confer cardiovascular protections. Meta-analysis of multiple SGLT2 inhibitor cardiovascular outcome trials demonstrate their impact on MACE, MI, stroke, and CV death. Across large randomized studies, SGLT2 consistently reduced risk with a pooled hazard ratio close to 0.90 versus placebo. While these findings highlight their dual role beyond glycemic control, they deliver strong cardiovascular protection in type 2 diabetes. While this meta-analysis of major SGLT2 inhibitor trials shows a consistent 32% reduction in hospitalization for heart failure, with a pooled hazard ratio of 0.68. In contrast, there was no significant effect on stroke outcomes. Overall, these findings highlight the strong heart failure benefit of SGLT2 inhibitors in type 2 diabetes. Having seen how SGLT2 inhibitors deliver consistent hemodynamic and renal benefits, particularly in reducing heart failure hospitalization, let's now turn to GLP-1 RAs. Here, the evidence highlights their strength in atherosclerosis, cardiovascular protection with clear reduction in major adverse cardiovascular event, cardiovascular death, MI, and especially stroke, with a 17% reduction on fatal and non-fatal stroke. In patients with established ASCVD, both GLP-1 RA and SGLT2 inhibitor reduce major adverse cardiovascular event to a similar degree. However, SGLT2 inhibitors show stronger benefit in preventing hospitalization for heart failure and slowing kidney disease progression. Their distinct clinical profiles, GLP-1RA for atherosclerotic protection and SGLT2 inhibitor for cardiorenal outcome, should guide individual treatment decision in type 2 diabetes. As early as 2023, the ADA introduced what we now call the Temple of Diabetes Scale, also referred to as the ADA 2023 Pillars in Diabetes Care. Now, this framework visually unified the key domain of management at the base, lifestyles, and education as the foundation. 4 therapeutic pillars: glycemia, blood pressure, lipids, and agent with cardiorenal benefit, all supporting the pinnacle or peak of this temple of diabetes care, which is reduction in diabetes complications. Now we go to the FLOW trials. FLOW trials is a global study testing whether semaglutide can slow kidney disease progression in people with type 2 DM and CKD. Over 3,500 high-risk patients were randomized to semaglutide or placebo with outcome focused on kidney failure, major eGFR decline, or death from kidney or cardiovascular causes. Its goal is to determine if semaglutide, already proven for glucose and cardiovascular benefit, can also produce kidney protection. The FLOW trial, completed in 2024, showed semaglutide reduced the composite kidney outcome by 24% versus placebo, lowered CV death by 29%, and cut all-cause mortality by 20%. The study was stopped early after interim analysis confirmed clear benefit. Now, this is phase 3 ESSENCE trial. Is evaluating semaglutide 2.4 milligrams in patient with biopsy-confirmed MAS and stage 2 and 3 fibrosis. There were 800 participants that was randomized to semaglutide or placebo with interim analysis at 72 weeks and final readout at 240 weeks. The part 1 focused on the histologic endpoint, resolution of steatohepatitis without worsening fibrosis and improvement in fibrosis without worsening in steatohepatitis, which form the basis of accelerated approval. Part 2 extend to long-term outcomes with cirrhosis-free survival at the primary endpoint at 240 weeks. So, the ESSENCE study, semaglutide shows histologic benefit at 72 weeks, and the part 2, a long-term endpoint cirrhosis-free survival readout due 2029 to confirm durability and full approval. In MAS, F2 and F3, semaglutide 2.4 milligrams achieved 63% resolution of steatohepatitis versus 34% with placebo, and 37% fibrosis improvement versus only 22% on placebo. Both outcomes were significant, showing semaglutide dual benefit on inflammation and scarring. In other words, semaglutide 2.4 milligrams improved both MAS resolution and fibrosis in F2, F3 patient versus placebo. Resmetirom stands as the first FDA-approved drug for MAS, acting through a liver-directed mechanism. Meanwhile, semaglutide 2.4 milligrams received US FDA approval on August 15, 2025 for treatment of metabolic dysfunction-associated steatohepatitis. As of 2026, resmetirom remains the first liver-directed therapy, while semaglutide is positioned as the first metabolic therapy for MAS, complementing resmetirom liver-focused approach. Now, the ADA 2026 standard of care now provide a structured treatment algorithm for muscle D across disease stages. For early muscle with F1, F0 and F1, for DM and or obesity, therapy focused on lifestyle, weight loss, metabolic agents such as GLP-1 receptor agonist, the dual incretin agonist, pioglitazone, and SGLT2 inhibitor. In patients with F2 and F3 at risk for MAS, resmetirom is introduced as the first liver-directed therapy, while semaglutide is the only GLP-1RA approved for MAS. In compensated cirrhosis, this agent may be used cautiously, but in decompensated cirrhosis, only insulin is recommended, with all other pharmacotherapies avoided. This algorithm highlights a stage-specific approach, moving from weight and metabolic control in early disease to targeted liver therapy in advanced fibrosis, while emphasizing safety in cirrhosis. With the advent of these therapies, the ADA EASD now frame treatment of type 2 diabetes around cardio-renal risk. Two drug classes have proven in CV outcome trials to lower major adverse cardiovascular event. GLP-1RA primarily deliver an anti-atherosclerotic benefit in reducing MACE, while SGLT2 inhibitor reduces MACE with their strongest impact on heart failure, hospitalization, and kidney outcomes. In April 2026, AACE redefined type 2 DM management. A1C is no longer the sole therapeutic target. The new algorithm emphasizes individualized complication-centered care, integrating obesity, cardiovascular, renal, and metabolic risk reduction alongside glycemic control. The 2026 AACE standard of care algorithm is built on 10 guiding principles. It begins with lifestyle modification as the foundation of therapy. Weight loss strategies are strongly emphasized, and pharmacologic choices are guided not only by glycemic targets but also by comorbidities such as obesity, ASCVD, heart failure, kidney disease, and muscle D. Treatment decisions are tailored to both glycemic goal and comorbidities, with rapid adjustment to avoid therapeutic inertia. Here I would like to concentrate and focus my discussion on the principle number 3. Comorbidities-driven glycemic strategies begin with lifestyle measures, then tailored therapy to comorbidities rather than A1C alone. Recommend to use SGLT2 inhibitors and GLP-1 RAAS across heart, kidney, and vascular disease, guided by new evidence that have been available in recent years. Set individual targets, titrate quickly, and layer agent to broaden risk reduction. In 2023, American Heart Association introduced the CRHM syndrome classification system, showing how chronic metabolic conditions like diabetes, obesity, hypertension, and dyslipidemia can progressively affect multiple organs. This staging framework helps primary care clinicians detect disease early, tailor treatment to each stage, and avoid inertia. It also supports the use of new evidence-based drugs such as GLP-1 RAAS, SGLT2 inhibitors, and dual incretin therapies that have proven benefit in protecting the heart, kidney, and liver, reinforcing the need for integrated multi-organ care. Now, in JAMA 2024 data showed that CRHM syndrome is widespread. Only about 1 in 10 U.S. adults remain at stage 0, while nearly half are already in stage 2 with overweight or obesity. Over 90% fall between stage 1 and 4, underscoring that CKM is a population-level issue rather than a rare late-stage condition. For primary care, the key insight is that most patients are already at risk, yet often asymptomatic, and staging offers a framework for early intervention, tailored therapy, and prevention. Now, in 2025, ACC and AHA guidelines set blood pressure goal by risk. High-risk patient with CBD, diabetes, or CKD should aim below 120 mmHg, while most with CBD target under 130. Low-risk adults start with lifestyle changes, adding medication only if level stays at or above 130 over 80 mmHg. Pregnant patients should remain below 140 over 90 mmHg. And stage 2 hypertension or high-risk cases require drug therapy at 140 over 90 or higher. Overall targets are risk stratified to balance benefit and safety. The total cholesterol should be under 200 milligrams per deciliter. HDL above 40 is protective, while very low level are a red flag. LDL target tighten with risk less than 100 milligrams per deciliter for most, and less 70 milligrams per deciliter for ASCVD or diabetes, and less than 55 for every high risk patient. Triglycerides should stay below 150. Fasting with values above 500 considered severe. So let's review the KDIGO heat map that shows that chronic kidney disease staging in type 2 diabetes uses both GFR and albuminuria. Albuminuria is graded as A1 to A3 and GFR ranges from G1 to G5. Together, they define risk, guide treatment, and set monitoring frequency. Light colors indicate lower risk with less frequent follow-up, while dark colors mark patients at higher risk for progression and CV event. The ADA stresses that heart failure is a key complication of type 2 DM, making routine screening essential. Adults should start with biomarkers like NT-proBNP or BNP, followed by echocardiogram if abnormal, with ECGs also recommended. Diagnosis requires elevated biomarker plus evidence of congestion. For prevention, guidelines emphasize blood pressure control below 130 over 80, monitoring microalbuminuria and eGFR, lifestyle changes, RAAS blockade, and BMI checks. The slide shows that SGLT2 inhibitor and GLP-1 receptor agonists deliver broad metabolic, cardiovascular, and kidney protection that complements standard therapies like statins. MRAs and ACE inhibitor or ARBs, SGLT2 inhibitors, have the strongest evidence for renal and heart failure outcome, while GLP-1 RAs excel in reducing atherosclerotic cardiovascular event. Now, put it together, they lower risk of MACE, CV death, albuminuria, and eGFR decline, forming a dual foundation of modern cardiorenal metabolic care. So this figure portrays diabetic kidney disease care as a temple supported by three pillars: RAAS blockade, SGLT2 inhibitor, and non-steroidal MRAs like finerenone. Together, they provide the structural support needed to slow CKD progression and reduce heart failure risk. In the fidelity pooled analysis of patients with CKD and type 2 diabetes, finerenone significantly reduced the risk of composite kidney outcome compared with placebo with a hazard ratio of 0.85. It also produced a sustained reduction in albumin to creatinine ratio over a period of 48 months. Remarkably, 87% of the kidney protective effect was explained by the improvement in albuminuria, underscoring finerenone's role in slowing CKD progression through anti-inflammatory and anti-fibrotic pathways. More recently, from 3 pillars to 4 pillars of CKD prevention and treatment in type 2 diabetes. Lifestyle modification is the base, followed by RAAS inhibitors for kidney protection, SGLT2 inhibitor to slow progression, non-steroidal MRAs like finerenone for anti-fibrotic benefit, and GLP-1 receptor agonists with emerging evidence of renal protection seen in the FLOW trial. Together, they form a comprehensive evidence-based strategy for cardiorenal risk reduction in diabetes. So the international guideline now place SGLT2 inhibitors at the center of the cardiorenal metabolic care. Major societies in diabetes, kidneys, and cardiovascular medicine recommend them as a foundation therapy in type 2 diabetes, CKD, and heart failure. Notably, SGLT2 inhibitors are the only drug class with a class 1A recommendation across the full left ventricular ejection fraction heart failure, backed by strong evidence for reducing CV death, hospitalization, and kidney disease progression. Even with the strong supporting evidence, the real-world use of SGLT2 inhibitors and RAAS blockers remain limited, particularly outside of diabetes care, leaving many high-risk patients undertreated. Now, this DCRM 2.0 is a multi-specialty consensus framework published October 2024 that integrates diabetes, cardiorenal, and metabolic disease management into a unified, evidence-based latest approach. It emphasizes organ protective therapies, lifestyle foundations, and coordinated care across specialties, and on over 28 pages. The DCRM 2.0 reframes diabetes, cardiovascular, renal, and metabolic disease as one continuum. It recognizes shared drivers like insulin resistance, inflammation, and adipose dysfunction, and calls for unified cross-disciplinary care. The emphasis is on early intervention, risk-stratified management, team-based collaboration using therapies with multi-organ protection such as SGLT2 inhibitors and GLP-1 RAAS. The goal is integrated management that reduces cardiovascular event, preserves kidney function, and improves survival. Now, let's turn to the management of comorbidities within the cardiorenal metabolic spectrum, signaling the shift to integrated management of overlapping heart, kidney, and metabolic condition. For management of heart failure with CKD is unified across ejection fraction categories. Diuretics ease congestion, while SGLT2 inhibitors anchor cardiorenal protection. For reduced heart failure ejection fraction, quadruple therapy with ARNI, ACE inhibitor or ARB, beta blocker, MRA, and SGLT2 is standard. For preserved ejection fraction heart failure, GLP-1 receptor agonists add metabolic benefit with selective ARNI or MRA use. Monitoring relies on NT-proBNP or BNP, and albuminuria with RAAS MRA therapy must be adjusted for hyperkalemia or eGFR decline. The ultimate goal is unified protection of the heart and kidney along a single continuum. Now, hyperkalemia and eGFR decline requires careful adjustment if you use RAAS blockers and MRAs. Now, for CKD prevention and management, risk assessment, number 1, and then lifestyle therapy. Management with CKD plus diabetes, use SGLT2 inhibitor, non-steroidal MRA, and GLP-1 RA. And CKD without diabetes, RAAS inhibitor plus SGLT2 inhibitor. Define CKD study is a finerenone trial in non-DM CKD such as glomerulonephritis, hypertensive nephropathy, IgA nephropathy, assessing kidney and heart outcomes. When DCRM 2.0 was written, this trial was still ongoing. However, last June 5, 2026, defined CKD results were disclosed, showing that finerenone improved eGFR slope and reduced the risk of composite renal cardiovascular outcomes in adults without diabetes kidney disease. Now, regarding muscle D and MAS, the muscle D and MAS pathway begins with screening patients with metabolic risk or type 2 diabetes, excluding other liver disease, and stratify risk using mp4, which is a non-invasive test, or other non-invasive tests like ELF, Enhanced Liver Fibrosis Test, VCTE, which is Vibration Control Transient Elastography, or Magnetic Resonance Elastography. Low-risk patients are monitored annually, while higher risk group undergo secondary assessment or hepatology referral. Management is fibrosis guided. Lifestyle therapy is the foundation, with pharmacotherapy like resmetirom, pioglitazone, SGLT2 inhibitor, GLP-1 RAAS for advanced disease or condition. The goal is early detection, fibrosis-based care, and multi-organ risk reduction. Now, implication for management. Now, this chart shows how diabetes drugs differ across cardiorenal metabolic outcomes. For GLP-1 RAAS and dual incretin agonists offer broad benefit for ASCVD, heart failure, kidney protection, and weight loss. For SGLT2 inhibitor also provides strong cardiorenal protection but carry infection like UTI and fungal infection risks and are contraindicated in dialysis. Metformin is the foundation unless eGFR less than 30. Insulin sulfonylureas grenades lower glucose but raise the incidence of hypoglycemia. TCDs increase heart failure risk while DPP-4 inhibitors may modestly raise it. Choose therapy by balancing benefit and risk across organs. So in summary, the key takeaways is that CRHM or cardiorenal hepatic metabolic conditions are common and serious, so early intervention is the key. Integrated care reduces complications like diabetes, heart disease, kidney disease, and heart failure. Newer agents such as SGLT2 inhibitor, GLP-1 receptor agonists, MRAs, and RAAS inhibitor provide multi-organ protection. So team-based, risk-aligned care ensures these therapies are used effectively to protect the heart, kidney, and liver. And with that, I would like to close my presentation and thank you for listening.